Hello, and welcome to Dr. Hussein Wahab YouTube channel for medical education. Today we will discuss about Brodie's abscess. Brodie's abscess was its first described by Benjamin Brodie in 1832. Brodie's abscess is a contained infection in the bone marrow, surrounded by a sclerotic wall, thus leading to little systematic inflammatory response. A localized form of subacute osteomyelitis. Basically, it is a localized form of subacute osteomyelitis, most commonly affecting long bones of the lower extremities of young adults. Typical age of this disease is 11 to 20 years. Metaphysis is the most common site involved. Before physial closure, the metaphysis is most often affected. In adults, the metaphyseal epiphyseal area is involved. There is history of insidious onset, intermittent pain of long duration. On examination, there is localized tenderness. Typically, a systemic reaction is absent. Supportive laboratory data are inconsistent. The white blood cell count is normal or slightly elevated. The erythrocyte sedimentation rate is slightly elevated. C-reactive protein is also slightly elevated. Blood cultures are usually negative. Findings of radiographs are described as plain radiographs, lytic lesion with a rim of sclerotic bone. A hallmark of Brodie's abscess is the formation of a sclerotic, thickened bone wall around the infection.
Findings on magnetic resonance imaging or MRI, signal intensity is decreased on T1 weighted images of the lesion. Signal intensity increased on T2 weighted images as shown in next slide.
MRI is useful for discriminating subacute osteomyelitis from other bone lesions. Penumbra sign on MRI as it is shown in this image of MRI, T1 weighted MRI hyperintense rim of granulation tissue, penumbra, around the low signal fluid-filled abscess cavity with surrounding marrow edema of low signal. The penumbra sign is a thin rim of granulation tissue that lines the abscess cavity in cases of subacute osteomyelitis. According to literature, the penumbra sign on MRI is helpful in distinguishing between subacute osteomyelitis from other osseous lesions. This sign on MRI has a sensitivity of 75% and specificity, positive and negative predictive values all higher than 90% in the diagnosis of subacute osteomyelitis. The differentials of Brodie's abscess include osteoid osteoma, Langerhans cell histiocytosis, chondrosarcoma, eosinophilic granuloma or tuberculosis. Microbiology, organisms of low virulence are considered to be the cause of the Brodie's abscess. Staphylococcus aureus is a gram-positive spherically shaped bacterium, is cultured in 50% of patients. The culture is negative in 20% of the patients. This condition often requires an open biopsy with curettage to make the diagnosis. Treatment. The gold standard for Brodie's abscess management is surgical debridement, incision and drainage, that is removal of the necrotic and infected tissue and long course of antibiotics, usually up to 6 weeks. Indications for surgical intervention. Surgery should be reserved for aggressive lesions in case of aggressive subacute osteomyelitis with ESR higher than 40 mm per hour, abscess larger than 3 cm, a lesion indistinguishable from a tumor. Open biopsy for culture and histology is indicated. Curettage of metaphyseal cavities. Curettage of metaphyseal cavities should be carried out carefully, and perforations in the growth plate should not be curette, because curettage of the metaphyseal lesion usually decompresses the epiphyseal lesion. Indications for bone grafting. If surgery is undertaken for subacute osteomyelitis lesions that measure more than 3 cm or in cases in which bone is weak and subject to fracture, the cavity could be filled with bone graft or bone graft substitutes. The cavity could be filled with bone graft or bone graft substitutes, primary or delayed. A drain is generally indicated to avoid hematoma or seroma accumulation, which can lead to recurrent abscess, unless the surgeon is completely confident with regard to hemostasis. Long-term monitoring. Follow-up should be done at least up to 2 years. In the first week, the patient should be closely monitored for signs of response to treatment. Antibiotics should be continued for 6 weeks. Most recurrences occur within 6 months, but recurrence after intervals as long as 18 months has been reported. Radiologic healing is slower than clinical healing and usually occurs within 3 to 12 months. We present a case of 20-year-old boy, laborer by profession, who presented to clinic with complaint of pain right knee for 2 months. Initially had fever for 1 week. Pain more prominent on prolonged walking and at night. He visited multiple doctors, and he was advised antibiotics, including linezolid, amikacin, ceftriaxone and ciprofloxacin. No improvement in pain. On examination, a young boy of average build and height, no erythema on knee joint, normal range of motion of right knee, tender anterolateral aspect of proximal tibia, no effusion of knee joint. Laboratory data was ESR was 50. CRP was 49. White cell count was 6,400.
This is preoperative radiograph of knee joint showing a lytic lesion with surrounding sclerotic rim in metaphyseal region of proximal tibia, marked with red arrow. This is preoperative MRI of the knee joint. Both T1 and T2 weighted images are shown. Penumbra sign on MRI is visible. Preoperative workup was done. Patient was prepared for surgery. Incision and drainage if the lesion done, as it was a large defect, so bone grafting was also done in same setting. These are 3 months post-operative x-rays. The patient is fully mobile and has returned to work.